Novel urine biomarkers for monitoring disease activity in juvenile lupus nephritis, a prospective longitudinal validation study. This is from 2 centers in the United Kingdom, and Dr. Watson will present.
So I'd like to thank the organisers for inviting me to talk to you this afternoon. I'm going to be presenting some work that we've looked at looking at urine biomarkers and how they may be useful for monitoring disease activity in juvenile lupus nephritis. And in particular, I'm going to focus on the results from a prospective longitudinal study. So I'm going to just present to you some cross-sectional data looking at univariate analysis and the multivariate analysis of renal biomarkers in juvenile lupus, and then show you some of the results from a longitudinal study, and then just briefly mention how the kidney cells may be directly expressing these biomarkers, and that's why they prove to be so strong in lupus nephritis. So this work's done as part of the UK juvenile lupus cohort study, which includes a number of different centres across the UK and has a number of different components. And when we've previously looked at the data from the UK JSL cohort study, we can see that a high percentage of our patients have renal involvement, both at presentation and after 5 years of recruitment when we analyse the data. And in fact, this is almost up to 80% after 5 years of recruitment. So we were quite keen to try and understand more about the renal disease and look for better ways that we can monitor the disease. And one way to monitor disease is through biomarkers. And we were actually quite keen to move from a very reactive manner to a more proactive manner using biomarkers. So say, for example, here we have disease activity up this axis over time here. And as the disease gets worse, there becomes a point when it's clinically obvious and we can detect the disease. So say, for example, with lupus nephritis, this could be the presence of proteinuria. And hopefully we would start treatment and see the disease would begin to settle again, and at a second flare we could detect it at a later point. And we're quite keen to try and detect some novel biomarkers so that we can detect disease at a much earlier time point and hopefully try and prevent some of the irreversible damage that we might see in the kidney during this period over here. So in current clinical practice, there's a number of biomarkers that are already in place that we use to monitor the renal involvement in lupus. And these include proteinuria, double-stranded DNA, ESR, complement levels, lymphopenia, the creatinine, or the estimated GFR. But we're interested in novel biomarkers and how these may be useful in monitoring disease. And one of the most promising of which is monocyte chemoattractant protein 1, or MCP1. And this is an inflammatory chemokine which has a role to recruit inflammatory cells to the area where it's expressed. And it's been shown to be expressed directly from the kidney and can be measured in the urine. And what's important is that on a cross-sectional basis it correlates with disease activity, and on the renal biopsy it's shown to correlate with the more severe histological classes, so class 3 and class 4 lupus nephritis. And the second most promising biomarker is NGAL, or neutrophil gelatinase-associated lipocalin, and this again is an inflammatory protein that can be expressed from the kidney and can also be measured in the urine. And other studies have shown that it does have a good prediction factor in that it can predict renal flares at an earlier time point. So what we're quite keen to do is try and move biomarkers, which are within the literature at the moment are staying in the planning and discovery phase, through to validation and ultimately to the benefits of our patients towards commercialisation. And so we hypothesised that in juvenile onset lupus, in our cohort of patients, biomarkers can be useful to try and monitor the changes in renal disease activity over time. And what we aimed to do was to compare novel biomarkers with standard biomarkers, initially on a cross-sectional basis, and then to see which one of these may be independently associated with renal disease, and then to look over time to see whether our biomarkers could predict changes in renal disease in our patients. So we recruited patients taking part in the UK JSL cohort study, and we used the 2 largest recruiting centres, which were Great Ormond Street in London and Alder Hey Hospital in Liverpool, and we included children who had a diagnosis less than or equal to 16 years old, and all patients had greater than or equal to 4 of the SLE ACR criteria. And at every clinical opportunity, we obtained urine samples, blood samples, we completed a bilag, and we measured the standard and then the novel biomarkers within the laboratory. And we recruited patients over a 27-month period. we defined disease activity to have improved if there was a change in active renal disease from a renal bilag score of A or B to an inactive renal bilag score of C, D, or E, and those patients to have worsened over time if they changed from an inactive renal bilag of C, D, or E to an active renal bilag of either A or B. And we undertook statistical analysis, and the study had full ethical approval. So we recruited 64 children with a median age at diagnosis of 11.3 years, and almost 80% were female. They had a median disease duration of just over 2 years, and they all met the SLE classification criteria. At the time of study entry, the average age was 14.1 years, and we captured just about a year of follow-up, which was divided into 3 clinical episodes per patient. And this represented the time between episodes of 112 days, so approximately 3 months between patients' clinical episodes. And we had a range of ethnic backgrounds, with the majority of our patients being Caucasian. And so when we looked on univariate analysis, we put all of our novel biomarkers along with our standard biomarkers, and we split our patients into whether they had active renal disease or inactive renal disease. And as expected, there are a number of different markers which are associated with active renal disease, and many of these were highly statistically significant. So we then went on to do multivariate analysis to try and identify which ones were independently associated just with the renal involvement. And what we saw was that the only 2 independent predictors of active renal disease were urine levels of MCP1 and the complement 3 titers. And these were highly statistically significant. So we then went on to do a longitudinal study to follow patients to see whether we could predict at an earlier time point the changes in renal disease. So we measured our biomarkers at the earlier clinical review, and then we looked at whether the subsequent disease had improved or worsened with respect to the renal component. And we analysed the data using receiver operating characteristic curves, plotting the sensitivity and specificity to give us an area under the curve value. And what we saw when we looked at our novel biomarkers again and our standard biomarkers again, and we looked at improved renal disease over time or worsened renal disease over time, what we saw was that the only predictor of improved renal disease over time was urine MCP1, and the only predictor of worsened renal disease over time was urine NGAL. And if we look at the ROC curves for both of these, here we have MCP1 and improved renal disease, and we can see that it has a good area under the curve value of 0.81, which is statistically significant. And we can begin to develop optimal concentrations that may be able to define whether the disease will improve over time. And this is really important because it may be able to lead us to be able to titrate some of the medications more carefully if we can predict which patients are going to improve. And then if we look at NGAL here, we can see that NGAL was significantly able to predict worsened renal disease activity. And again, we can begin to look at optimal concentrations. And our areas under the curve represent excellent and good biomarkers, respectively. So just finally, I'm going to show a small amount of data where we've looked at how the kidney cells can express these biomarkers directly. And what we did was we exposed the kidney epithelial cells, the podocyte cells, either to macrophages, because these are thought to be the first cell to enter the kidney in lupus nephritis, or to some cytokines which are well known to be linked to lupus. And so we exposed podocyte cells to macrophages, or TNF-alpha, or interferon gamma, and we measured the gene and protein expression of the biomarkers MCP1 and NGAL. And what we saw was that when we looked at our podocyte expression of MCP1, it was the macrophages, when they were in an activated state, that were able to induce MCP1 to be released from the podocyte cell. And when we looked at NGAL, the macrophages didn't seem to affect the NGAL expression from the podocyte cell, but the cytokines, both interferon gamma and TNF-alpha, both led to an upregulation of NGAL. And we can see here on our graphs that compared to normal podocytes, interferon gamma and then TNF-alpha as well, both led to the upregulation of NGAL from our cells. So just to summarize, there's a high occurrence of renal involvement in juvenile lupus. And using a very realistic cohort, we've identified that C3 and MCP1 are both independent markers of lupus nephritis. MCP1 is able to predict whether a patient's renal disease activity is going to improve, and this may be because it's such a strong cross-sectional marker in that if you have it at a normal level at the time that when you see them earlier, they're subsequently going to improve. And what has been shown by us and been shown by other groups is that NGAL is a very good predictor at demonstrating whether renal disease will worsen over time. And finally, the fact that they're so specific may be related to the fact that they're being expressed directly from the kidney cells. And perhaps we need to begin to try and validate some of these and move them towards our patient benefit to the point of commercialisation, so we can begin to look towards biomarker-led early intervention and monitoring to try and improve the outcome in our patients with lupus nephritis. So just to finish, to acknowledge the multidisciplinary team who helped with this work, and I'd welcome any questions.
Comments or questions? Yes?
Hi, I'm Lily Lim from CICS Toronto. In your longitudinal part of the study, the biomarkers, have you looked at how far ahead of time can you predict disease flare and activity?
Yeah, we haven't. What we looked at was that at the review earlier, which on average was 112 days between the reviews, we could detect it. What we're now going to try and do is look at kind of serial markers and look a little bit more closely if we monitor the patients more intensely to try and get optimal thresholds and try and get a definite cut-off so that we can be confident at a certain time interval when this is going to change and what change is happening. But this was preliminary validation to just try and see whether these actually worked in a realistic cohort.
Thank you.
I may have missed this, but did you show reversibility in the novel biomarkers with improvement of disease?
I haven't shown that, but what you do see is that the biomarkers fall back down at least to within a nearer normal baseline. But patients who have previously had active disease and then go into remission, we see that their biomarkers are comparable to the ones who haven't had renal disease. So it does look like that they happen to be an acute event and then things begin to fall again.